All right, so we're going to talk about tapering, as I said, and you've heard it a couple of times. It's a super hot topic, and I'm just going to present some data and then also raise items for discussion about this. One of the things that I think it's different to us, tapering, and that is because when we grew up in years back, certainly before the biologics, it wasn't something that I think we would have predicted. And there are several reasons for that. One, as you see here, this is the immunopathogenesis of rheumatoid arthritis. And you all seen this, the role of T cells that are driven into the inflamed synovium, interact with other cells. This is what gives us many of the targets that we're now able to specifically inhibit with some good results. But at the top of it, what you see when it says endothelial cells, you see the flat endothelial layer, but also those chubby, high endothelial venial cells, and you only get them in areas of immunologic activity. So if you biopsy a joint of a person with burned out rheumatoid arthritis, 30 years, they've never been on any therapy, swollen joints, this is what you see, saying it's immunologically active. So that really brings us pause to why would we stop treatment unless we've cured this immunologically active systemic autoimmune condition? The other thing I think that when we were new to the agents that we're now talking about tapering, we remember growing up like this. This is a very early study, Larry Moreland's study published in the 90s, New England Journal, and we saw this. This is early studies. Remember, you don't know if something's safe. So you treat, but then you stop it. And here, when you stop, you see what happens. Everything goes bad. These were the worst of the worst patients that we were putting in studies. They had failed everything we had back until then. But when we stopped these new drugs, as good as the new drugs were, as soon as we stopped, they acted up. So that's the background upon which I think most of us grew up with an inherent bias that tapering treatment, stopping treatment is not a good idea. It's not going to work. Well, things have happened since then. You've heard a lot and a lot presented here. We have different treatment modalities. We're treating more aggressively. We treat to target, treating earlier disease. So now this is an idea we're beginning to think of. One expression of this is an analysis we did at the Corona database and just said, many of you know of Corona. I bet some of you are Corona investigators, you're patients in your practice. And we just looked at patients who had gotten their first TNF inhibitor, and the patient and the doctor decided to stop while they were in low disease activity, CDI less than 10. We don't know exactly why, presumably because the patients who were doing pretty good wanted to stop. I mean, that happens to us in the clinic all the time, doesn't it? So what you see here, and as I mentioned in the earlier talk, these tapering data seem to me glass half empty, glass half full. If you look at the survival estimate, you look at that, and you might say, well, gosh, almost everybody fails. And failure was very conservatively defined here. If you did anything, if you added prednisone, if you went back on TNF, if you changed the dose of your DMARD, anything you did meant that you failed. Well, see, eventually, almost everybody fails, meaning the disease comes back or needs treatment. But if you look at these are months down the bottom. So you could see that in terms of people going out a year, 73% did. People going out a year and a half, just over half the people did. At 2 years, 40+% of the people are still doing well off their TNF inhibitor. So you can get away with it. You can get away with it for a pretty long period of time for some patients. The difficulty is predicting who, and that's what we'll come back to at the end. We don't know who can stop and be in drug-free remission. We don't know who can taper and still do well. We looked, one of the interesting things which I think we need to explore more is that the speed with which you respond initially. So for a lot of these people, we had data on when they began their TNF inhibitor, and those who got better faster, and you see these people in your clinic. You talk them, you say, look, you need to be on something else, you put them on a TNF inhibitor. Next visit they come back, they think you're the smartest doc in the world, they're feeling great, versus someone else who they come back and they say, yeah, I'm a little better, and you look at their DAS and you look at their Rapid 3 and their CDI, and they're better, but you say, well, look, you're better at 3 months, let's give it a few more months to see how much better you're going to get. The people who do faster do better in terms of being able to taper treatment. So here's a study that I think highlights some aspects of this. This is one of the earlier studies of discontinuation. I'm mixing these concepts up, tapering and discontinuation, because I think there's a ton of data. Some studies do one, some versus another. So this is Optima, and here the idea was to take patients on, the most interesting groups were at the top, arm 1 and arm 2. Take patients methotrexate plus TNF inhibitor, in this case adalimumab. They do well. Well meant DAS, low disease activity on 2 separate occasions, and either they continue or they stop. And I'll just point this out. One of the difficulties with study design with this is we were most interested in arm 1 versus 2. That was the cool part of it. To get 100 versus 100 patients, we started with about 1,000. So when you design these studies, and people have said, well, gosh, why did you pick DAS low disease activity? Why didn't you pick DAS remission? Because to get patients in DAS remission, we would have needed 2,000 patients to start. So there's an issue between what's practical and what's going to give you at least some information with all these studies. There's always trade-offs. Anyway, this was the most interesting part. Who can get into low disease activity persistent, stop the TNF inhibitor, and still do well? And here are the data. So what you see, and you look at their clinical responses for ACR20, it looks that doesn't seem to matter. If you're doing well, you continue to do well. So if I run Kaiser, I'm like, yeah, discontinue therapy. That's the way to go. If you look at ACR70, however, you see that, well, there are some people who seem to have done better because they stayed on the TNF inhibitor compared to those who discontinued. You look at the x-rays, you see the same. You say, well, mostly there was very little progression, but there are probably some people who should have stayed on the TNF inhibitor combination because they progressed less. So that's always the trade-off with those, is that when you stop it, there are some people who probably should have been better if they had stayed on it, whereas some people get away with it. And we don't know how to identify those patients. Are there any negative consequences to this? Another theme I'll come back in and out of throughout the talk. Well, in the BEST study, you guys are familiar with the BEST, really pivotal study, excellent study, one of the great ones in rheumatology ever. And what they did is try to get people well, treat to target early rheumatoid arthritis, compare different strategies. If you just look at the people who are in the biologic, when they were in remission twice in a row, they had to come back on treatment. So they came back off the biologic. What happened to those people? Well, here you see that half of them for whom they started to do this, half of them were able to. As Professor Keystone said, overall, this is about 15 to 20% of people across the different groups were able to come into drug-free remission. What happens, though, if you look at the right-hand side? Well, you look at some people, most people who lost remission got it back, but there are about 8% of people who never got remission, never got even to low disease activity. So those people probably shouldn't have stopped because they're doing worse now. Now, do we know if they had stayed on therapy, they wouldn't have? We don't know that, but it's still an issue of some concern. What are things we can look at in the clinic that may help guide us? Well, flares. We know this. Patients doing well, they come in, they blame it on the weather or the gluten or whatever, that they are having a flare of disease activity. We give them some steroids maybe we see what we can do and say, is this going to persist? But flares matter. And you look here, this is also analysis from the BEST. The progression of x-rays over time on the bottom left, progression of function over time on the bottom right, and you see you certainly do better if you don't have flares, but 2/3 of the people in BEST did have flares. The more flares you have, the worse you're going to do. So as we're tapering strategies, as we're discontinuing, can we watch the patient and say, we'll keep a close eye, and if you flare, we'll jump back in. But as you saw on the last slide, recognize that sometimes you won't capture things completely. What are the predictors? Again, Yoshia Tanaka has been a real leader in this field. This was the HONOR study, different than what we saw before for the HOPEFUL study. The point of this is one of the things that predicts persistently doing well is how well you do. If you see on the top right there that Yoshia here said, well, if your DAS 28 was really low, not just remission, 2.6, but below 2, then you have a pretty good chance of staying either in remission, 68%, or remission, or low disease activity, 79%. If you were in remission, but your DAS was between 2 and 2.6, so you're still technically in remission, but a little more inflamed, then you have less chance. So that's, he would say, kind of a sweet spot. You're following someone in the clinic, you're doing DAS scores. If they're super low, then maybe they can do well if they stay off therapy. To me, though, it also, these data, which other studies have also shown, are a bit tautologic. It's like if you're fat, if you're 300 pounds and you want to get below 200 and you get to 199, well, you're not fat anymore, but 4 days later, you're 201, you're back in the fat category. Whereas if you're 205 to start and you lose to 150, and you're not going to get to 200 until 6 months from now or 12 months from now. So it's when you have a goal that's fixed, you always have a chance that the better you do, the slower it is. And indeed, if you look at the individual graphs, it seems there are certainly a lot of people who are slowly crawling up, which kind of fits with the data that we saw from the corona. The DRESS study, another study at tapering. A nice study, I think, because it did a couple of things. One is that it looked at a dose reduction strategy, which I don't think would be atypical for what either our patients would do on their own or what we may instruct them to do if they say, hey, doc, can I cut down on therapy? We say, well, why don't you cut down on it a little bit? So here you see they're spreading the interval. They're not injecting less drug. The drugs are adalimumab and etanercept, TNF inhibitors. They're just spreading the interval, and what they're looking for are major flares compared to those who just follow along with their doctor and worked with the doctor to get the best outcome. So what happened? Now, major flare is 2 flares in a row. Kind of the reason they picked that is that, well, they said lots of people flare. And if you flare and you get a dose pack of prednisone and then you're better, that's not that big a deal. So the major flares were not different. So the primary outcome then is that tapering is not inferior to usual care in terms of flaring with major flares. But if you look at any flares, you sure had a lot more flares as you started to taper. Other things which I think are sort of interesting, the amount of steroid used. Of course, as you'd bet, it's more in the tapering group. DMARD stopping happens more in the usual care group. DMARD increasing happens more in the taper group. So you're stopping or tapering the biologic, but you're going to these other therapies perhaps a little bit more. In this, there was also no predictor of treatment, no predictor of the ability to stop treatment. Also in this study, very interestingly, there was no difference in side effects. I think when patients come to me and say, I want to taper or I want to stop, it's usually cost, but it's also concern for side effects. You read about these side effects, you're always thinking about them. If I'm on less drug, that must be less chance, but this was not seen in that study. What predictors did they look at? They looked at a lot of them, including the drug levels. So in the drug levels, they were not able to find it. And that's kind of a, gosh, wish that had worked out, because it totally makes sense if you have one patient and you start tapering their TNF inhibitor and the level drops too low and then they flare versus somebody else whose level was higher, but it's not that way. In fact, it had absolutely no correlation. In this study, they also looked at the MBDA or the Vectra. They found no utility of it whatsoever in predicting who would flare, different than the retro study, which I have a slide on, and different than another study. So it's a real mixed bag, and it's still very hard to predict who we can successfully taper. This is another study. This is the STRASS study. Just put it up there similarly because it's another nice study where they started to taper. They were not very successful. Here you see in the bold, the third bullet, 43% of patients were able to taper or stop. The average reduction was 28%. So as you think of also the pharmacoeconomics of this, if you're tapering someone, well, that's great. If you're on 28% less drug, that's drug you're not spending. The drugs can be expensive. But are you coming to the doctor that much more often? Are you getting other therapies that you would need to account? And here too, I think pretty much the case is closed on drug levels, because here they looked at drug levels, found no predictability. This is the POET study. POET study I put up here for a couple of reasons. One, it just got published. I don't have this on the slide, but here too, the MBDA did not predict who was able to continue. So you have DRESS and POET where it doesn't work. You have retro where it seemed to work very nicely. This I put up to call your attention to the adverse events, which was, that's why a lot of people think that they may want to taper, because they don't want to get infections. They don't want to get serious infections. But here, if you see in the bottom bullet, adverse events actually happened a little bit more, including hospitalizations for those who stopped treatment. They weren't able to give rationale for this. You'd say, well, maybe, are they using more prednisone? I don't know. This wasn't in the publication. The authors could not say, when I asked them, they couldn't say why. They had no reasonable explanation. But it certainly says that if you're going to stop treatment or taper it just because you're worried about safety, I'm not so sure that that's a good idea. And that kind of fits with what we know about biologics, isn't it? That if you're going to get things like infections or serious infections, they tend to happen earlier on. And if you take a group of people in a study such as this who had been on therapy, mostly you've selected out the patients who were going to have the infection, and these are the survivors who are doing well on this particular mechanism of action. I'm talking a ton about TNF inhibitors, but there's increasing amounts of data, or are increasing data on other mechanisms of action here. Abatacept in early rheumatoid arthritis with or without methotrexate, getting people in DAS remission. You stop everything, almost all of them flare, and it doesn't take so long for them to flare. And a bit of warning, if you will, in that when you flare and then you put them back on treatment, that's good, but you may not get exactly what you want, and you may not get it fast. So here you see among the people who flared, 120 people, a lot of them did get back into remission. A lot of them got into remission or LDA, but there are about a quarter of the patients who, at least as of now, going out past 6 months being back on treatment, they're not in L disease activity, and they were in remission when they stopped. So I use these data when I talk to the patients. I very, very seldom initiate dose tapering. Patients are always doing that, it seems to me. And I tell them I'm totally fine with them doing the experiment with themselves. I want them to report it to me. And also, they need to be aware that the risk, if you will, of this is that if they're doing fantastic and they cut down therapy and they're not so fantastic, it's not a slam dunk that they're going to go right back on therapy and do as good as they were doing. It may take them a while, or they may not get back. And we know this actually goes back to the early 90s, the Tenvoldi study done with traditional DMARDs, which showed the same thing. If you take people in deep remission, stop their treatment, they flare, you put them back, you don't always capture them straight away. The retro study you heard about from Dr. K, so I won't go over this in length, but here it looked as if the MBDA was actually a nice predictor. And here you see the spread of people who were able to stop, those who were not able to stop. And while there are some outliers, certainly it looked as if it added a piece of information, and that if the MBDA was low, you were going to be more likely to stay off therapy, taper off therapy, particularly if you were ACPA negative. The supplementary material is in the bottom right, and I think that's very interesting, and it's always been my contention with the Vectra. It's a fantastic idea, but I'm not sure that there's a single one-size-fits-all Vectra. Here, if you look at them and just look at the discrepancy between the purple bars and the blue bars, you can see that some of the analytes are different and some are not. So I think you could probably take this and maybe create a taper Vectra, or a taper Vectra that was specific to the individual agent, to say that this may, if you have a different question, so we saw the data about X-ray prediction, which seemed to be very robust, but if the idea is tapering, maybe you need a different recipe of the analytes weighted in different ways that could predict it. But we have to see, and it's not clear why it worked. It seemed to work very well in this study and not in the POET and not in the DRESS. Studies are similar but completely different in terms of the populations, the agents that were used. So a lot that we still have to learn. Why is it so difficult to taper? Going back to the past, if you think back in the days, and here's the old Pinal's criteria for remission. Nobody used them because before we had biologic agents, we weren't getting anybody in Pinal's remission. But interestingly, if you go back to the paper, it's a brilliant paper. What they say is complete remission implies total absence of all articular and extra-articular and immunologic activity related to RA, meaning that you should go in the joint and make sure that there's no active immunopathogenetic changes there, but you can't do that. So they settled with these 5 of 6 elements over 2 consecutive visits, and you just look at those. I mean, for the young people who have not seen this, think of those patients in your clinic. There's a lot of them who will never, ever get Pinel's criteria because they're so stringent. Interestingly then, and get to the idea of what's targeting and what's the appropriate targeting before we think of tapering therapy or stopping therapy, there's a paper that I think was very widely under-recognized. I always thought it was a brilliant little paper. And this came from the group in Rochester. And what they did is they had a bunch of patients, 14 patients, who were going to get surgery. They were planned to get orthopedic surgery. And what they did is to examine them clinically, they took 14 patients who were in deep remission, Pinel's remission. That's tough remission. Then they got the synovial samples. This is not part, it wasn't, the patients were already planned to undergo surgery. So they said, hey, while you're in there, give us some of the synovium. And on these patients, they also did ultrasound for some of them and MRI for some of them. What they found is a lot of stuff. And they found that even though these people are in very deep remission, they had a lot of active immunologic change, and they had activity on highly sensitive imaging. So this says, well, gosh, maybe we're failing this taper thing or this discontinuation thing because we're just not getting people in deep enough remission. Well, that's starting to be looked at. There's a couple of studies looking at, and I don't know that that's the answer. On the one hand, it does make sense that if you look at, this is a study that looked at regular dose versus low dose etanercept clinically, both of the doses did well, but the ultrasound was worse in the patients on the lower dose. So it makes sense. Maybe our clinical definitions are not stringent enough. We need more stringent definitions. Well, this has been looked at in a study from the UK where they tried the tapering thing, but tried it in people, only in both people who are in ultrasound remission as well as clinical remission. And here are the data as you see here, and they didn't necessarily do that much better. So asking that people are in ultrasound remission isn't the simple solution that says, yeah, this is what's going to do it. And this fits with the Arctic study, which was published earlier this year, a treat-to-target study where they had treat-to-target with clinical, treat-to-target with clinical plus ultrasound, and the ultrasound didn't add anything to the ultimate outcome. So even though the patients to get ultrasound outcome had a little bit more rearrangement of their therapies, a little bit more therapy, it didn't get them better clinical outcomes. Why is this so hard? Can we put all the studies together and get a consensus? Well, Georg Schett and colleagues published a review from last year that's already way out of date because there are other published studies, but they went over 26 of them. Difficulty is that they differ in so many important ways that you really can't combine them. And here are just some of them. What is it, stop or is it taper? What's the target before you stop? How long have they had disease? Is it early RA versus later? How active were they? What about other therapies? So there are so many differences in these studies that there will never be a meta-analysis because you can't, because the studies are a little bit too heterogeneous. So we try to learn from them bit to bit. And then the other aspect of it, which I haven't really said much of anything about before, but you read any old textbook article on rheumatoid arthritis, and this is what you see. The first sentence has to be this. It's like the introductory sentence of the Iliad. Rheumatoid arthritis is a chronic, progressive, idiopathic, autoimmune, systemic inflammatory disease. But what are we talking about? The whole lecture so far I've been talking about peripheral joints. So we're leaving aside cardiovascular issues. We're leaving aside bone health and osteoporosis, pulmonary disease, the risk of lymphoma, which you know is increased in patients with increased disease activity, the risk of infections that's inherent to uncontrolled disease. This is a Canadian study. Ed, give a shout out to your colleagues here, looking at different therapies and cardiovascular events. You can't read this, so let me blow it up. Look at the TNF inhibitors, as I think we have come to expect, and now there's good data that shows this, say that they lower all the types of cardiac events, MACE, heart failure, and all cardiac events. So tapering them, this whole idea of tapering do we ignore the issue that inflammation that we're controlling with our therapies leads to cardiovascular outcomes? What do we do if we taper and the patients aren't doing well? Well, give them some non-steroidal and some steroids. No, not for cardiovascular risk, because clearly they make that risk higher. So I think in the back of our minds, and it comes up in the clinic, and if I have an older person who is CHF and has diabetes and hypertension, still smoking, wants to stop the TNF inhibitor, I'm thinking, ooh, I don't know how good an idea that is, because I'd hate your CRP going up. Somebody who's younger, psoriatic arthritis patient with no comorbidities, I might think of it, but I think this has to be in the back of our minds. I mentioned this earlier, so I won't repeat it again, but I think this is a lovely scientific area. Can you taper therapy? Can you stop? I just hate the idea that it's almost certain that we're going to see this thrust upon us. It's happening around the world. Can't imagine it's not going to happen to us here as well. And as Jack mentioned, it is part of the ACR guidelines. The ACR guidelines say, not necessarily unreasonable, that if you're in remission, maybe you should consider tapering or stopping, but there's not data. This is like a lot of guidelines, this sounds kind of reasonable, and the key unmet need is we don't know which patients. Some patients can taper, some patients can stop, they can still do well. We need to watch them, we need to treat if they flare at all, but we don't know how to identify other than doing it. So for the time being, I think for me, what I see is that the patients do this, and all I ask is that they're doing the experiment, they report the outcomes to me.